Well, hey, nurses, you've been gaslit into believing the foundation of good mental health is psychiatric medications. But newsflash, it's not. We are your whistleblowing shrinks, Dr. Terrelyn and therapist Jen, and you have landed on the Gaslit Truth podcast. And our guest today is David Wayne. Welcome to the show, David.
Hey, I'm happy to be here.
Okay. All right. Let's talk about who you are because your bio is fantastic. I
think you should be a writer, not a
This
nurse.
one
But
made me
anyway,
giggle. I love it. This one made me giggle. Okay, so David is a registered nurse. He has a background in hospital psychiatry. He was trained to tell his patients that their depression is caused by a chemical imbalance and that antidepressants are a safe and effective way to treat depression. Ignorance was bliss. Now he knows better, and David screams into the void in a futile attempt to effect systematic change in establishment psychiatry. According to his critics, David is a dangerous anti-science conspiracy therapist with questionable hygiene. He is also the obligatory male nurse on Nurses Out Loud podcast, which we will talk about today. Welcome to the show, David.
Thank you.
what's up with the questionable hygiene? That's where I want to
Oh,
start.
I'm seeing it. I'm seeing
I'm
it.
seeing
Like,
it. Go to
Yeah.
YouTube. You can see Dave's
everybody,
questionable
like
hygiene.
when we're talking about maintaining adult daily levels of functioning, I can see David does not have it together. So we might have
Yeah.
to work on that.
That would
Guilty.
be charted in a note somewhere, probably.
Yes,
Right?
yes.
Yeah.
The disheveled is there, so I'm afraid you have a psychiatric disorder, likely
I
schizophrenia
didn't
or
think this was so
bipolar.
bad for sleeping outside.
Yeah. Schizoaffective disorder, more like Jen, right?
Oh, yeah.
The
Okay.
one.
Shoot, you're right. You know what?
Yeah.
Write that one down.
Look how we
Oh,
did that. So quick. So
everything.
quick.
Look at that. There you go. There's your 7 minutes with a mental health provider in the United States appointment done, labeled. David, we will get you a medication and move you on.
Appreciate it. I feel
All right.
seen, so thank
You
you.
feel seen and so
Yeah.
much better.
Yeah.
So much better.
We're happy
Oh
to
my
have
God.
you here, David. Tell us why you came to this show, why you wanted to come on here, because we're so excited to have you.
Well, I had listened to a few of your prior episodes that really connected with me. The first one was with Kelly Fulkred. That was a great one. And then you had uh, Robert Whitaker on. And,
The man.
the
Damn it,
man.
Bob.
Yeah. I've been kind of following him for years. I refer to him as that bastard Robert Whitaker because of how he completely upended my life with his book Anatomy of an Epidemic, which is just a
I think
game changer for
offline
me.
you said fucked up my life, and I'm like, we agree
Yes.
with that
Yeah.
100%. You can't turn
Yeah.
back now. No
Yeah,
way.
You said you had told us in your Google form that everybody fills out, right? Everyone, before you come a guest on the show, we get a little bit of information on you, and you talk about this like inability to even like read research anymore.
Yeah.
From just
Yeah.
like the normal good old, like I would call it like good feel good blind eye of reading research. Like, oh, look at that
Exactly.
study. Look how great it is.
Yeah. In nursing school, we're taught evidence-based practice. I mean, it is the mantra. It's just drilled into us, but we were not taught anything about how rampant fraud was. So back in my naive days, I would, read a study and it's like, okay, this is peer-reviewed, published in a reputable journal, and you could, read the conclusions, read the synopsis, and be like, all right, I know that now. Cool. And now when I read clinical research, it's like, okay, who funded this study? Was there a ghost author? Does their data actually match their conclusions? Is there anonymized patient level data even available for public scrutiny? Who funds the publisher? It's like it becomes
Damn it, Bob, you
paralyzingly
fucking-
complex. It's like, well, I don't even know, like, what do I even do with this now? Like, okay, now I don't trust anything. How do you even begin to cut through when you've been lied to, so profoundly? Like, how do you even begin to know what to trust anymore?
That's
So,
true. That's true. I want to touch on a point here because there are so many research articles out there that start giving you data that you're thinking, oh, they're going to do it. They're going to go down to this place that nobody wants to hear, and then they will backpedal in the end.
Oh, yeah.
And I'm like, oh, come on, just
Mhm.
do it. Just say the thing that nobody is courageous enough to say. And they probably can't. Right.
Yeah.
Yeah, they can't, because then they won't get published.
Right. Or funded or whatever it is that they're trying to do. So
Mhm.
so how long have you been a psychiatric nurse?
So about 13 years now.
13 years. Is this where you started, or is this where you migrated to?
It's where I started, but not by my choice. Basically, when I was in nursing school, our senior year, people got to pick which unit they would do their senior synthesis on.
Mm.
And I wanted to be in the ER because I had been an EMT. So, but nobody picked the psych unit. So I kind of drew the short straw and got placed on the psych unit because nobody wanted to be a psych nurse in my class. So
Damn it.
I got placed there essentially against my will, and it
Oh, that
just
sounds like a consumer
I know,
story.
yeah, yeah, exactly. Yeah, I was placed under Chapter 51
Yeah.
and, brought from the classroom to the psych unit, and no, but
And
it
you've stayed ever
I
since.
stayed. It clicked because, I enjoyed the patient population, and I really enjoyed the other nurses who were drawn into that area of nursing. They were just some of the best people you could ever hope to work with, so, yeah, it clicked.
That's awesome. So when you think about that, so you were standard nursing practice, right? For a long time.
Yeah.
When did you pick up that book?
It was about 2017. It was about 2017, and it was kind of multiple things happening at the same time that were starting to open my eyes, and it came at a time that was I was kind of at, like, the pinnacle in my establishment nursing career because I had been taking on additional responsibilities, like I'd become a charge nurse. I had joined just about every committee that existed on my unit. I'd become a committee chair. And in that year, in 2017, I actually won my hospital's Excellence in Nursing Leadership Award.
There
So
you go.
I was like,
Sounds so familiar, Jen, doesn't it?
Oh, I know. I'm like, man, why we all did this.
Yeah, we all
We
did it.
all did this.
and I was great at my job. I mean, I feel like I can say that and have it not be arrogant because, hey, they
Mhm.
gave me a huge award. And uh, but Robert Whitaker's book came into the picture and started me down these rabbit holes and started to read about other things that had kind of been on my radar. Everybody's kind of familiar with OxyContin and just the incredible crimes committed around that drug and the way that people were told, by Purdue that it's only about 5% addictive, and they knew that was a lie. And we don't have to go too far in that direction because there's, entire documentaries and things like that out there
You can go as
about
far
it.
as you
But
want. You can go as far as you want in the
all right.
story. Yep. Mm-hmm.
Well, everybody's kind of familiar with OxyContin, but then you read about things like Vioxx too. Vioxx was pulled off the market right about the same time I started working at a Walgreens pharmacy. I worked in a pharmacy while I was in nursing school,
Oh,
and
interesting.
as years went by, more and more lawsuits happened around Vioxx, and these revelations came out that were just incredible. The way that Merck had intentionally hid cardiac side effects. They knew these cardiac side effects were there and were happening, and that they had to hide them in order to maximize their profits off these medications. So things came out like these email chains where they're talking about, boy, it's a shame that it's a mechanistic harm that's happening, but man, we're going to make a lot of money. Or emails that would, I mean, their vice president of clinical research was saying things like, hey, I know how to design a clinical study that's going to hide these side effects. And it's just,
Yep.
it crumbles a lot of different worlds at the exact same time because everybody kind of suspects that pharma companies are gonna fudge numbers a little bit to try and get away with stuff, but realizing it was that bad to the point where they were willing to let tens of thousands of people die for profit, like that's pretty dark. Not just that they would do that, but that the FDA, you find out, was basically complicit in that. And then the justice system was complicit as well because, okay, they fined them a few $1 billion, but it wasn't as much as their profits and nobody went
Right.
to prison. I think it's fair to say, murdered tens of thousands of people and nobody went to prison. They just had a few $1 billion fine that was less than their profits. Like, how is this our system? How is this acceptable?
Yeah.
This is unbelievable, but it's right there in the court case. So
Yeah.
So
So that is that when you picked up the book? Like I'm trying to get to the part where you're like, how did you get that book in your hands? Like, what was the deciding moment that you actually even read that book itself?
I had had some conversations with people, and I had seen uh, Joe Rogan podcast, um, and he had a psychiatrist on there who was talking about some things, and I started to fact check some things, and it's like, oh, it turns out that
That
was
is true.
true, and
You were
then
trying
that
to fact check him to the negative,
trying
like
to
you're
trying to
yeah,
fact check him to the negative, like that can't
yeah,
be right, and then it's like,
yeah.
oh, okay,
Oh,
and then
wait.
yeah, and then, get the book, and even the critics of the Robert Whitaker book, even the fact checkers with his book, their criticism is basically, well, he's not wrong, but he just takes his conclusions too far, and it's like,
Mhm.
oh, okay.
Yeah, yeah, it's hard to question. It's hard to question the truth to that book when pretty much, I mean, everything he pulled out of there came directly out of their own research.
Yeah,
The lines are
right.
verbatim out of the studies. I mean, like it's hard to go back and question that.
Yeah,
But I wonder for you. So when you got your hands on that, were there things that you realized when you after you had read? And we keep saying that. So guys, we're talking about Anatomy of an Epidemic, the book that Robert Whitaker wrote. Once you read it, did things start to click? Did you go back and kind of start to go, okay, this is why patients aren't getting better, or these are the lines that I have been programmed to say to people that are actually grossly inaccurate? Like, were there these truths that just pop and then all of a sudden these connections were made once you got your hands on that?
Yeah, that's exactly what happened. I went back to my psychiatric nursing textbook, and it says in there that people's depression is caused by a chemical imbalance and they'll need to be on these safe and effective medications for the rest of their life. And I even went to my hospital's own patient education resource vendor where we would get our handouts about, what is major depressive disorder or what is this antidepressant. And I started looking at those, and those also said, depression is caused by a chemical imbalance that's treated with safe and effective medications. And I just started clicking around and found out that our vendor was Merck. It was literally Merck. It was the
Oh,
pharmaceutical company that killed 60,000 people with Vioxx, and they were writing our patient education handouts for
Oh my god.
antidepressants and for depression and for that sort of thing. And so um,
mm,
this was all kind of a very um, painful process as well, because it's like it's your whole worldview is kind of
Mhm.
getting shattered to some extent, and you have this idea of yourself and you have an identity built around this career that you have, and all of a sudden it's like, oh, this so-called evidence that we've been following is actually a lot of fraud. And it's not just that it's fraud around profit, it's doing a lot of harm to people, because boy, when you find out about PSSD too, and
Mhm.
you've
yeah. Oh,
been
we're going to talk about that today because
okay,
I was hoping you would dive into that a little bit. Yeah.
yeah. um Yeah, it's just very distressing. It's just very, gosh, ignorance is
So how
bliss. I was
so
much
it
happier.
yes, because I was gonna ask you, Jen and I talk about this, and we're like, I don't know that I could go back into the system, knowing now what I know. I don't know that I can practice back in a system like that. How do you keep practicing in a system like that?
So what I decided was I am obviously not going to be able to exert systemic change. I'm just a psych nurse from Wisconsin. Who the hell am I? I'm not going to like change how things are run at the FDA or anything like that. So, but I am in a position on my unit where I have a lot of respect and I know all the right people. I can change things locally. So that's what I decided I would do. I decided, like, hey, we're going to get rid of all this Merck propaganda, and I'm going to rewrite all our patient education handouts, because that's the sort of thing that I
Ah.
had done before. So we're getting rid of all this nonsense about the chemical imbalance. We're going to use the latest research. And the lowest hanging fruit I decided to start with was about PSSD. I was like, you know what, I'm going to start with this one. This is something that if patients aren't told about this, they are not getting informed consent. So we're just doing a real short, quick patient education handout about the sexual side effects of SSRIs. And I decided to start there. And
Can you tell everybody a little bit about that? I think some people listening may not know what PSSD is.
sure. So PSSD is post-SSRI sexual dysfunction. And what this looks like is it's incredibly common for people to have sexual side effects from antidepressants. In fact, when you look at the number needed to treat, antidepressants are far more effective at causing sexual dysfunction than they are at treating depression. So this is a well-known, very, very, very common side effect. But what many people don't know is that this side effect can persist after discontinuation. And of course, we in the mental health establishment didn't know about this for a long time because all the safety studies are done by pharmaceutical companies that don't want to find out about things like PSSD. So they're not studying it. They're putting blinders onto it because knowledge of it could possibly threaten profits. But there is growing evidence. We know this is a thing. We don't know how many people it affects, but I've talked to multiple people at this point who have experienced this, and it is just absolutely devastating. It's just absolutely devastating. It's you take an antidepressant and it numbs you. And for some people, the goal is they're dealing with this distress. They're incredibly dysphoric. That numbness is a relief to the despair that they were feeling, and they can make some progress in their life. But it also causes physical numbness for a lot of people. It causes genital numbness. And we don't know exactly what the mechanism is that does this, but for some people, it does not go away. They stop taking the medication and they are still physically numb. And
Oh, they're still emotionally numb too often.
they're
I
still
mean,
in them. Yes, exactly.
mhm.
It's not just that they're
It takes
physically.
sometimes it takes a while to reconnect your head back to your body,
Yeah,
right?
it severs them from their own humanity. It's they have the birth of a child and they don't experience any joy. They experience the death of a parent and they don't feel grief. They've just been numbed physically and emotionally. It's just it's
Mhm.
horrific, and a lot of them end up committing suicide, unfortunately.
Yes. Yes. I mean, I think that's the biggest side effect that nobody wants to talk about. But I want to talk about that. But first of all, I want to just, and I could be wrong because I'm not that adept with PSSD, but is it kind of like a spectrum? Um, because I think like just even the thought of sexual desire goes away.
Yes.
Is that part of PSSD? I'm gonna guess.
Yes. Yep,
Okay.
tanking the libido,
Yeah,
absolutely.
just
Yeah.
just that, like, it's not even on your mind ever at all,
Right.
and down to, genital numbness and inability to have sex, right, or perform.
Correct.
So
Yes.
there's a wide spectrum of symptomology with PSSD. The weird part is I think I'm gonna grossly generalize because I was a woman who probably could have been diagnosed with PSSD when I was using an SSRI. It practically ruined my marriage, but not just from sex, but just from lack of connection, right? Like
Mhm.
it's not just you don't want to have sex, it's you don't want to connect. Like there's no who cares, right? At this
Exactly.
point. Um but I think with women, and I think this is a valid discussion, if a woman goes to a doctor and says, "Look, I don't wanna have sex, I don't wanna connect, I don't wanna whatever," she might get told that that's okay because, this is about your depression, not about your sex life, and your husband or partner needs to pipe down over there because it's not about his sex life, it's about your mental well-being. Whereas if a man maybe went in to the doctor and said, "Listen, my penis doesn't work anymore. I can't get an erection. I can't do these things." He might be met with a completely different conversation. Because we look at sexuality very different with men as and women. Men are the bad guys who always want sex, and women, it's optional in their life. And I'm like, pleasure and intimacy are not optional pieces of life. They're actually the human condition. So when we strip people of the very basics of humanity, connection and socialization and just intimate relationships. We've stripped them essentially of their humanity. But I think there's like such a different response with men and women when we come and have that same complaint, right? The complaint about sex drive or intimacy or functioning, not being able to have an orgasm as a woman is very different than not being able to have one as a man. So do you have you noticed that? I know you do more inpatient psych than the day-to-day stuff, but do you notice that to be any different? Like, do we treat men and women different when they present with PSSD or any other side effect? Do you see a difference inpatient?
Yeah, I think that's a fair observation, actually. Yeah, I do think men and women are treated a little bit differently in that regard. And, I have talked to some people who have said, my depression was so bad, any sexual side effects were worth it. So,
Yeah.
yeah, but it comes down to informed consent. Like you have to tell people that this is a possibility, and if somebody's in an intimate relationship, I think that
They
it's
need to
something
know.
that's they need to know. It's going to impact the relationship, so everybody needs to be informed. That's a foundation of our healthcare system, is informed consent. So
Yeah.
Mhm.
Unfortunately, I wish we could even, drag that informed consent even deeper because there are Facebook groups and things around SSRIs have destroyed my marriage.
mhm.
And the conversation in there is a lot about lack of intimacy and connection to partner. And I think that could even be part of the informed consent process. Like you may feel disconnected from yourself and from your
Mhm.
partner and from your children and from the world eventually, right? That might be what happens. But as we know, reading Robert Whitaker's books and things like that, like not Robert Whitaker, who's the other guy? Spellbounding guy, Spellbind.
Bregan.
Cool.
Peter
Yeah.
Bregan.
Peter
Peter
Bregan.
Bregan. Peter Bregan, when you're in the throes of all of that, you don't realize that that's what it is.
Mhm.
And we're willing to trade it all out for good mental health. And again, I would argue that disconnection from yourself and from other people is probably not good mental health, right? We know that from COVID. I
Absolutely.
mean,
Yeah.
that's something that we have learned, that's like we know that before that, but that's like a big example of what isolation does to you and lack of connection with people. So it's very interesting. Mhm.
Yeah.
Yeah. Well, and we did
I
a
thought
we did a as I'm sitting
oh, I'm
over
sorry. I
here
think there's
and
a
as I'm
little delay.
sitting
Sorry
are
about
you
that.
cutting out? Yeah, you got a glitch, it's fine. We did an episode
Mm-mm.
on this, Dave, and we talked
Yep.
about antidepressants, like ruining marriages.
Mm.
And I think people have a hard time wrapping their brain around how that could possibly be. But then when you start to offer examples about PSSD, or when we start to talk about the emotional disconnect that is there even when you have children, right? And it's just like another day. Well, it's a Tuesday. I had a baby, right? Or you have a big loss in your life, and you're the stoic one that has no tears and is kind of just numbed out funeral after funeral. It I think that those examples help put that in a realistic place for people. And I'm glad we talk about PSSD. I get quiet over here, like with my fidgets, because I'm pretty damn certain that that's something I'm going through right now after 20 years of an antidepressant in my body. So it's a very good thing to talk about, because I do believe, even beyond the sexual side effect of this, the disconnect emotionally, and the inability to connect in that way with somebody is so numbed out. And I
For
think
sure.
people can really resonate with that. I would go so far as to say people who are unfaithful in their marriages, or people who cannot be there present with their children. We can trace this right back to SSRIs
Mhm.
and what they do, especially for people who have a significant long-term use of those SSRIs, for sure.
Yeah, because I think the conversation is just almost slightly different if we just focus on sexual side effects.
Yep.
The way words matter,
Yep.
right? If we're just talking about sex, well, I don't care about sex right now. I
Mhm.
care about, not being depressed.
Yep.
But if we talk about it in a level of intimate connection and
Mhm.
connection to self or others,
Yep.
that might be a different conversation that is still
Yep.
within PSSD. right?
Right.
For
Well,
sure.
and pharmaceutical intervention is very different as well. So if you're a male who's struggling with PSSD and you go into the doctor to talk to your doctor about this, there is a drug for that. Okay.
Yes, sir.
And there's a drug for it, right? And so you're starting to medicate a side effect. If you're a woman and you go in, you're told, well, there is no drug to fix that, and you might need to go see a couples therapist. That's what I was told. And you're kind of like, so then it's an internal problem. That's your problem.
Right. It's blame the
And there,
victim.
Yeah.
and there isn't a
The victim.
solution, right? The solution is you've got to go see a therapist because there's something wrong with you, versus the solution that's much more acceptable, that doesn't feel so blaming for a man, which is, well, here, we can give you something for erectile dysfunction. There's an answer for that. Here, there's a drug for it. So the way the speech around it is very different too. The solutions are different, which I think is very intriguing too, because there are no drugs that exist out there for women who are struggling with this like there are for men. There isn't a drug. I asked for it for years. Doesn't exist, right? So it's no, you've got a psychological problem that needs fixing.
They're right. The psychological problem was now a neurochemical imbalance created by the
I know.
medication that you're on.
Yeah, it's
So
great. It's great.
Yeah,
And the
yeah.
that's not how they were looking
provider
at it.
herself
So.
created it for me, and here
Yeah.
she's can't come up with the solution. But I'll digress from that. But I think it's an important topic to talk about, because something you said too, David, that I think is very interesting. So now there's more research that's coming out about this. But when you think about the etiology and the start of when PSSD was actually being researched, there wasn't a shit ton of stuff out there on it, because it's not as though the drug companies are going to go back, and nor did they go back. They did their 45 to 90 day trials at the jump, and they were done. FDA approves the drugs. Everybody's happy, we move on. When you look at PSSD, you have to retroactively go to the end. You've got to go to the people who have been on it for a while. You've got to start to do research around that. And that's not something that they do. Those drug companies aren't going to do research in that way. They research at the beginning, they do their little few months of it, and they kick out what looks good after people have been med washed and restarted on medications, and it looks good to them. But they don't retroactively go back and go, okay, we're going to take 5,000 people and we're going to look at the sexual side effects that have happened to them after 5 years, 10 years, 15 years of SSRI use. That doesn't happen.
No, it doesn't. So people end up having to crowdsource everything because nothing within the establishment system is going to help them. So they end up hopefully finding online communities where they find other people who are having similar experiences, and they can get some support from them, some peer support, and some problem solving, hopefully. But it's really quite the travesty that that's where we're at, that they have to find online support groups on social media for some of these things, because we know that this is affecting. I mean, we have 50 million people on antidepressants in the US or something like that.
60. Yeah.
60. Yeah. That's an insane number, especially when you look at the number needed to treat to even have an effect above placebo. It's like, in the latest data I looked at on UpToDate, which is the clinician reference tool where they kind of have a prescribing algorithm that has all the latest and greatest studies and data in it. Even in that tool, it says that the efficacy of antidepressants is about 53%, and about 40% of that is placebo effect. So these medications are about 13% effective on average, giving us a number needed to treat of 7. So you have to give antidepressants to 7 people to help 1. And that is according to data that this is directly from UpToDate, which looks at every single study in existence. They say that the data is low to moderate quality, medium to high bias, and very, very short term. And it's just incredible. It's just incredible to me. We talked about one of the foundations of our entire healthcare system being informed consent, but the other one is evidence-based practice. And it's like, you look at the evidence that's out there for antidepressants, and it's like,
it's so bad.
I cannot believe how many people are just on this treadmill throwing these out at patients every day. Like, this is the evidence that you're basing it on. It's astounding.
Okay, so So Terry asked you a question earlier, and I'm curious. So she asked you about like how do you continue to practice in a field when you know that there is like all this travesty that's occurring, right? And so you were talking a little bit about the things that you can do to bring informed
Yeah.
consent to patients, right? Like rewriting these manuals and these learning training materials,
I
right?
love
So
that,
Yeah.
by the way. That's
I
great.
do. Like
Mhm.
we just had somebody that was commenting online on another episode that we had, I think it was Nicole Lamberson on, and I had replied to their comment and I said, what these pipe dream things we have, right? Like these big ideas. And I'm always like, I would love to create a course, a CE course for healthcare providers that talks all about this, right? Like,
Yes.
and the idea of that ever happening is probably very meek because we're up against a very large guild who would never even allow us to come in and actually, I don't know, just talk about real research and truth for people to know. Okay. But that you just tucked that one away there, David Wayne, because maybe that's something because what you're talking about is that
Oh,
you're rewriting these materials.
I'm
Like,
very interested in that.
okay,
Absolutely.
hey, you start taking that on. You give Terry and I a
Well,
call.
All
listen,
right.
Yeah, we'll be
Yeah.
on that. Okay.
tag
But
us right in.
you
We'll be
got
tag teamed in.
All right.
but
Be good.
what I want to know for you then, like, can you tell us? So, are you like, how do you deal with prescribers? Because you're working with prescribers. Like, are they like who's actually giving these patients the informed consent? Like, so do they come in and they like prescribe their medications, and then do you like swoop in like Batman later and be like, I am David Wayne,
Yeah.
and give informed
Bruce
consent?
Wayne, David
Like, do you just
Wayne.
fly in and here's David Wayne, and then here
Yeah.
you come and go, let me tell you just a little bit more about these drugs before you say yes. Like, just here's everything you need to know. Like, how are you
Yeah.
balancing that?
How does that go down? Yeah.
Yeah, how does this
So
work?
so it's tough, right? Because a nurse has way less power than a psychiatrist,
Yeah.
than somebody who actually has the power to prescribe. And so, as I was working on these educational materials, the first one to go up to our medical director was the one I made about PSSD, and it got shot down. Uh,
Oh,
so
interesting.
I was told that it was outside of my scope as a nurse to be working on stuff like
Yeah,
this,
we're told
which
that
is
all
not
the time.
true. Not true
All
at
the
all.
time.
I had previously worked on other projects very similar to that. So that was just a bogus reason. What I heard through the grapevine is that he said that this education handout will make it too hard to get people on these medications. They're
They
going to
might
read this
say
and they're not going to
no.
They
start. They
might
might
say
say
Yeah,
no.
no.
they might say
And
Yeah.
no. Oh, too bad.
so it's like, all right, well, this fight's just getting started, and then COVID happened, and then everything kind of went on the back burner. Working in the hospital during COVID, so I was having those conversations with patients and telling them, more about the medications, and by the time they were on the psych unit in the hospital setting, it was pretty rare for them to be starting medications unless they were on the adolescent unit. The adults had already been on medications for years, but as I started to have conversations with people about things like PSSD and side effects like that, like it was once the blinders were off, I could spot it everywhere.
Yeah.
Uh, and then my hospital came out with a COVID vaccine mandate and denied my exemption and fired me a few years after they had given me an Excellence in Nursing award.
What?
Hmm.
That's a
Yeah.
whole different episode. That is
Yeah,
a whole
yeah.
different episode. Holy crap. Um,
Hmm.
this is just kind of it got me thinking about the people that come in that are already on medications and things. I'm starting to think like this. Okay, so if these medications are so fantastic and this is the pathway forward for our mental health care, how come the majority of people who go into inpatient psych as adults are already medicated but are so incredibly sick?
Well, it's their fault, obviously, because they
Oh,
have
obviously, yes.
treatment-resistant depression.
Oh,
Yeah, so then
yes,
they get
yes.
another diagnosis that blames the victim. Oh, this horrible medication where the number needed to treat is 1 in 7, and that's according to, like, really garbage data. Oh, it didn't work for you? Well, that's obviously your fault, so now we're gonna give you another diagnosis, and now we're gonna start playing with, we're gonna add an antipsychotic, we're gonna add a mood
Mhm.
stabilizer because obviously the problem here is chemical imbalance and we just need to give you more medication.
Well, that's true. It is chemical imbalance at that point.
Yeah,
Yeah.
it is.
It's so funny because it's like, the chemical imbalance theory is like somebody who's a virgin to all of this, then once you put everybody on these medications, now it is a chemical imbalance
Mhm.
problem.
Right. It's
We've
iatrogenic harm.
created, yes,
Yeah.
iatrogenic harm that we've created. So this is where people argue with me. I'm like, well, we're not talking about virgin users over here. We're talking about people that have been on stacked and all these things. That is a chemical imbalance that now needs to be accounted for, which then I keep thinking about med washing because I
Mhm.
know that so many people go inpatient psych and they get med washed, and that becomes their new norm, their new baseline, right? In a week, right? Or
Yeah.
whatever. Yeah, you're laughing. You know what I
Mhm.
mean? So can you speak to that a little bit?
I'm laughing, and it's just really dark because when they med wash people, "Oh, you've been on a benzo for 11 years? Well, we're gonna do a 1-month taper,
Yep.
and, oh,
Yeah.
look, there's your new baseline. You are in incredible withdrawal." Or, same thing
Yeah.
with SSRIs. You were on Prozac for 20 years and it's not working anymore.
Mhm.
Well, we're gonna taper you off it over the course of a month, and, oh, look, your depression came back. This isn't acute
Sometimes it's not even
withdrawal.
a
Yeah.
month.
Right.
Sometimes it's like the first few days they start messing with all this stuff, and that's your new baseline.
Yeah.
Look, we've created this new baseline for this person. Oh, you don't need that med anymore. Now you need this one because we've
Mhm.
seen your new baseline.
Yeah.
Um, yeah, that happens a lot.
So here's my next question. Do you come in like Batman with people and are like, just so you know, this is what's happening to you right now?
You're
Uh,
in withdrawal.
Yeah, like
yes.
you're in withdrawal and it could, I mean, like it could take months or years of that medication being out of your body to actually put you at what baseline actually is.
So yes, back in 2020, 2021, I was starting to swoop in like that, and I was waiting for the day where I was going to be called in for undermining the prescribers on the unit. And then we
Yeah.
actually got a new psychiatrist on the unit, a younger guy who was aware of protracted SSRI withdrawal, and he was actually starting to diagnose patients there with it. So I felt
Wow.
a
Wow.
lot of validation about that at that point. Like, see, I told you this is a thing and it's happening to our patients. And so was starting to make some progress. But then again, yeah, COVID and vaccine mandates and all that.
That's
Yeah.
that's an unfortunate thing. I need to have a whole episode about that at
Oh,
some point,
okay.
but
All right.
yeah, yeah, yes. Um, so when you're thinking about this personally, so what do you think the true root is of mental health? What do you think it is? Mental illness, I should say, not mental health, but what do you think it is?
Well, I think that there's a foundation necessary for every single person to have good mental health. And it starts with, you've got to get a good night's sleep. Your sleep hygiene starts right away when you wake up in the morning. And if you're not sleeping well, you're not going to have good mental health. There's also an aspect of moving your body and lifting heavy things. You need to get some sunlight on your skin. You need to have good nutrition. Could probably do a whole episode on nutrition.
Mm,
Actually, put a pin in that one. Let's talk about that one a little bit more. But you also need
Mhm.
some human connection, and to be part of a community, you need to have some other human beings around you that you connect with, and you need to have a purpose. And those things are missing in multitudes for so many people in our modern society. So many people don't have purpose. They don't have connection to other humans. Their nutrition is just, ultra processed garbage. They're not
Mhm.
sleeping. They're not moving their body. They're not getting sunlight on their skin. They don't have a connection to nature. Like, their problem is not a Prozac deficiency. It's all these other things. But the people who prescribe these medications, they're like, well, it's too hard to get people to change those things. People are stuck in their behavior patterns, and I can't get somebody to work out and to clean up their eating, so I just prescribe the Prozac and move on to the next person.
I think as
Mhm.
long as we keep saying that people can't and people won't, then we'll stop offering them those actual solutions, right? So I think like a psychiatrist could be a great project manager of someone's life, actually. Hooking them up with a dietitian, hooking them up with, even physical therapy
Yeah.
could help someone get moving. There's
Mhm.
all these things. You could be a great project manager for people, but instead, well, I can't get anybody. You're right. You can't just make somebody do something, but if you prescribe it, if you get put in a referral for a dietitian, they'll go. If you
Right.
put in a referral for PT, people will go, right? So
Yeah.
so there's like, yeah, they could be a great project manager for someone's life, but instead it's easier. It's also easier for a psychiatry to
It's
prescribe.
easier. Yeah.
Yep.
We've talked about it before too. People come onto the inpatient psych unit in the hospital, and the cost per day of being there is, at least 1,600 a day. If you're on the adult secure unit, it's 2,500, maybe 3,000 a day. And we think about these people who come in, and it's just imagine if you took that money and instead of putting them in an inpatient setting and starting them on meds, you had them attend cooking classes with other people who are
Yes.
struggling, and got them doing some goat yoga and
Yoga.
other
Mhm.
things where they're,
Yes.
actually doing things that help their mental health, connecting with other humans, giving them some structure, giving them some support and validation. Like, imagine how much better the outcomes would be, and it would cost way less.
Yeah. Yeah,
Yeah,
healthcare
well,
systems, prison systems, all the above. Like
Yeah.
that would gravely change the game. All of the money, all of the funding, the tax dollar money, everything. But that is an idea that while we're getting closer to it, it's kind of cool as time is moving on, right? Like these ideas are starting to come, I think, into the mainstream a little bit. It's an idea that like I also believe that there's such a level of ego that gets in the way of even having these discussions with patients, from prescribers. Um, there are some providers out there that are really great. They're open to listening. They are open to, like, when you were even talking about the psychiatrist that you worked with, the younger one who is like, hey, here's what protracted withdrawal is. Um, and I think there's less than more of that, as I think that's the unfortunate part of this as well. You can argue with a prescriber. There's so many people out there, and a lot of clients that Terry and I see for deprescribing that have to go in with this suit of armor to try to argue why it is that how they're prescribing is causing harm and how they're trying to get them off of these meds is causing harm. And there is such a level of ego,
Yeah.
truly, that gets in the way. We worked with over the years, I've worked 15 years, worked with so many psychiatrists in the prison systems. And of all of the ones I worked with, there was one that was open, and the rest were, there was like this hierarchy,
how
and
dare you?
they were at the
How dare
top,
you? Yeah.
and you
Mhm.
are out of your scope of practice. Like,
Mhm.
oh my God, if we had $1 for
Oh
every
my
time, we'd be
god.
fucking millionaires. Wouldn't be sitting here in this
I don't
makeshift
even
office.
understand that. Or
Like,
you're practicing
I
medicine by rewriting something, or
yes.
by
Right. By providing
sharing
information,
research,
sharing
right? Like,
research. Exactly.
There's this
right.
level of an accolade that I have reached, and you cannot threaten that. You will never be at that level. And I think that part is really dangerous.
Yeah, for
I think
sure.
psychologists are very much so. There's a huge group of them as well that are very much so like that. I find much less of that within like the social work realm, the therapist realm. I'm not saying that they're not there, but there's such a level of ego,
Yeah.
and how you get past that? It's almost impossible.
Well, it is. And,
David Wayne RN with bad hygiene and two first
right?
names. Who are
Yeah.
you?
Yeah,
Like,
exactly. Well, it's very ego protective, right? And it's also very distressing to acknowledge that this way you've been trained is actually doing a lot of harm,
wrong.
and that
It's
these
wrong.
power structures you believe in, like, are actually kind of full of shit and
Yes.
rife with fraud. That's very distressing. That shatters your whole worldview, and that's very painful. And part of me understands why people avoid going through that, but it's no valid excuse. I mean, I get it, but it's no valid excuse, because okay, what's the alternative? You're just going to plod along in your career
Yes.
with the blinders on willfully and hurt person after person after person, ruin their lives. Like,
That you can actually visibly see that this person is injured.
Yes.
Like, I
Yes.
can when I see a client who is injured, I can hear it in their voice. I don't even need
mhm,
to see the person. I can hear it in their voice. When I see them, I can visibly see that they are sick, to the point where I feel like I can walk down the street and know who is on a long-term SSRI just by their flat affect and the circles are under their eyes and all this stuff. And how can you not see? We were assessing people the way they look all the time in practice, and how can you not see that they are visibly sick and not connect the idea that these meds are probably the thing doing it? I guess I have such a disconnect with that you and I are in the same room and we see the same person here and they're very sick. Your answer is give them more. My answer is feed them some good food and
Right.
get them
Right.
moving around.
Right.
I
It's
don't how
it's
can we see the
amazing.
same thing, right?
This
It's
is where David's going to come in with the metabolic mental health. Here we go.
well, first
Here
I'll
you
just
go.
say
Here's your
it's
plug.
amazing that people trained to spot cognitive dissonance are completely unable to apply that lens to
Oh my
themselves.
God.
That's on a deliverable. Boom.
Yeah.
Done.
Metabolic mental health, though, yeah. If you guys want to talk about that,
Please do.
this
We've
is a
got a
big
few minutes
soapbox of
left.
mine.
Let's
Yeah, let's
go.
go.
Yep.
All
Yeah.
right, so my wife has an autoimmune disease called ankylosing spondylitis. It causes a lot of arthritic pain, especially
Oh.
in the back, and has been on every
Everything.
medication you can imagine for it, including Vioxx back in the day, actually, which spiked her blood pressure and almost caused her to stroke out if it hadn't been caught. But anyway, fast forward a couple decades into that diagnosis, and there were no real effective treatments. And she saw somebody talking about how the carnivore diet is good for autoimmune disease and decided, what the heck? I've tried everything else. What's the harm in just giving it a try? And so that was 5 years ago now. She hasn't eaten fruit or vegetable or grains in the last 5 years, and she is off all her meds. She's lost about 40 pounds. Her symptoms are in complete remission. And we've started to attend conferences and talk to all sorts of other people who have had similar experiences. They have autoimmune disease that they put in full remission on some sort of low carb, keto, or carnivore diet.
Yep.
And their stories are amazing, unreal. And one of the things that comes up over and over, it always makes my ears perk up as a psych nurse, is they say, I had Crohn's. It was horrible. I started carnivore. All my symptoms went in remission. I'm off all my meds. Oh, and my depression and anxiety went away as well. And
Oh,
it
shocking.
always makes me, pop up like a meerkat. Like, wait, what? And I've heard that from so many people at this point. It's unreal. None of them are changing the way that they're eating because they want to address their mental health. It's always for some
Never.
autoimmune disease. So there is
Yeah.
no placebo effect here, but they notice like, oh, and my mental health has
Yes.
improved incredibly from
Mhm.
changing my diet and getting away from sugars and ultra processed foods and all the chemicals and food dyes and that sort of thing. It's just been mind blowing to me. So then, that sends me down the path of reading books like Brain Energy by Chris Palmer or Change Your Diet, Change Your Mind by Georgia Eady. And I really think that the future of good mental health care is going to have a very large metabolic component to it.
And you know what sucks about this, and I hope it changes. I really hope this changes, David, is people like Terry and I, okay? We are told you're not a nutritionist.
Mm-hmm.
You don't get to talk about this. Now we are lucky in the state that we are in because some of the regulations for Wisconsin and what we can talk about within our scope of practice is a little bit better than some of the other states. Because Terry and I had to talk about this because I'm always like nutrition, let's go. She's like, okay, well, if you were in a southern state, these would be off limits for you. You can't talk about this shit as the therapist, right?
Right.
Which is ridiculous because that is so interconnected. Like all of these autoimmune diseases. Let's start talking nutrition.
Yeah.
Like, and a lot of times when we get people, we'll talk about the mental health part of it, it will go hand in hand. It's very rare that we have people that have these autoimmune problems that don't also struggle with anxiety and depression.
Right.
because
Well,
that's what
or
it
there's
come.
physical
Yes,
pain, anything,
physical
it's
pain.
all
That's why they
connected.
come to us, and
Mhm,
then you're going
mhm,
through their laundry list of history, and there's the medical
mhm,
conditions. Boom,
yeah.
boom, there it is. It pops, right? And there's the
mhm.
Crohn's, and like all the different things that are there. They just pop right in there, and it's like, okay.
Well,
You know,
if
it's go ahead.
I was gonna say, well, if serotonin is the happy chemical, like all those commercials told us, why is 90% of it in our gut?
Y Okay, so if this is how I started thinking about all of this, what, 10, 12 years ago or so? It had to be. I lose track of time. But anyway, I kept thinking like, okay, so if serotonin is the problem, I was Google searching when the internet wasn't very robust.
Dial
How do
up.
you make serotonin? How does a body make serotonin? Like, because we weren't taught that in school. We were not taught how you make serotonin. How does your body do this? Oh, wait, newsflash, protein is one of the biggest things that you need. And so when you talk about carnivore diet, yeah, no shit, right? Like,
Mhm.
yeah. Go to inpatient psych once. Are they high protein? Are they feeding them high protein?
Yeah.
No, they're not.
No.
No.
Go to an addiction rehab center once. Are they feeding anybody high protein? No, it's high sugar. So I think like this makes why do we just not tell people serotonin and dopamine and all the other neurotransmitters you need are basically made through protein sources, high protein. So just that alone can change someone's life who is eating a low or no protein diet, right?
Mhm.
And you don't have to be a nutritionist to know that. Like
Yeah.
that should be common knowledge,
It's
right?
fat too. Fat has been so demonized.
Demonize I'm
Yeah.
a
Correct.
'90s girl. Fat was like, "No fat, no fat,
Oh
no
yeah.
fat. That'll change your life." So
It's
the other part I wanted to say about this real quick is that you said nutrition isn't brought in for, pretty much anything or for mental health, and you're right, because I'll get people that come in and on their intakes will be like, "What is your number one goal in working with me?" And they'll say, "To lose weight." I'm like, "Well, nutrition is always paired with weight loss."
Mhm.
Yes.
And it's never the idea of my nutrition can change my mental health status. Well, if I lose weight, I will feel better, but maybe it's because you're changing your nutritional status as well, right? So nutrition is viewed for it's so hard, especially with women, viewed in a weight loss culture, not a mental health culture, and it certainly hasn't caught up. Like, nutrition's somewhat for, like, heart disease, diabetes, cholesterol, like,
Cholesterol. Yep.
a lot of times, your providers will say, "Well, change your diet," and that'll be the extent of the advice.
Yep.
But I never hear that in a psychiatrist's office
Right.
or in a therapist's office or even an inpatient psych. Change your diet. Because even in inpatient psych, they're not starting to change their diet. Like you said, if they had cooking classes or smoothie, I knew a lady who ran a rehab, addiction rehab, and part of their program was teaching them how to create nutrient dense smoothies. That was it, because they weren't cooking. So they're like, we'll do nutrient dense smoothies, and so that's what they taught them to do, and it was great, and they all felt better. It was weird, right? That's weird. Weird that you would feel better. So
Right.
I think if we could get the message out that nutrition is partnered with mental health care, and it should be the first thing you look at when
Yeah.
someone comes in, what's your nutritional status?
Yeah, you talk about low hanging fruit where,
That's the
the
lowest
risk
hanging
benefit
fruit.
analysis is
Yes,
just a grand slam compared to starting somebody on Prozac. Yeah, it's
right,
address their nutrition. But,
right.
you mentioned dietitians and how, recognize your scope of practice. The
Mhm.
dietitians are trained by the big ag companies, like their
Mhm.
They are.
textbooks are written by the people who are selling the Cheerios and that sort of thing. So
Well, not to
it's
mention, talk about scope of practice for a minute. Do you know how many dietitians do counseling for eating disorders?
mm,
They can do that, but I can't, teach someone how to make a smoothie. You know,
right.
I
Right. Yep.
I mean, it's silly. Like, it's
It
it's just
is.
it's all very
It's silly.
it's very silly, but I don't know why. Why do you guys think that people wanna believe that mental health is so complicated? Um, this is my conundrum of today. Like, why is mental health so complicated? The solution so complicated that nobody wants to do it. I don't view it as complicated, but people do. Like, I don't know, like it's
Well,
less complex to make it a medical disorder than it is to make it
right.
a person thing. I don't know.
In that complexity, there's plausible deniability for the predators out there who are making bank off of selling people things like antidepressants or complex combinations of medications. So yeah, if you give people that simple message and you give them ownership of their own mental health by empowering them to do all these different changes in their life instead of making them dependent on getting refills, that's why I think this system is the way it is. It's the establishment system protecting its own validity and shareholder value.
I'm at a point where like every time we have a guest, I need to write the word agency on something
I
and just
know.
hold like this.
Yeah,
Because every
huge.
person
It's
we
huge.
have on hits that
Yeah.
mark. Somebody, every person on the show has talked about that exact thing and that inner sense of agency and finding that empowerment and what that is. And
Yeah.
that's where I think the change really happens for people.
Yep.
Once you find that voice, that understanding, it's almost like this energy that you're given to get curious, to question things, to make a change, to do something different, even if it's something small. It's almost like once you find it, it's there, and you don't. It's recognizable, and you can never unknow it.
Yeah.
Yeah, it's just one of those things. So I'm like, I got to write that word, and every time we have a guest, I'm just going to hold it up because you're
Yep.
saying agency.
Yeah,
Don't
exactly.
give
Talking
it
about
away.
agency. You're
Yes,
talking
do
about
not give your
metaphor.
agency away. Yes. All right.
Well,
Well, I think we need to wrap up today's episode. What do you think, Jen?
Yeah, I think we're in a good spot, everybody. So we are the Gaslit Truth Podcast, and you know that you can find us anywhere that you listen to podcasts. We do have a little plug that we need to put in here at the end. For those of you that have been harmed by SSRIs or SNRI withdrawal, there is a call to action that's happening, submitting responses to the FDA's MedWatch, everybody. So there's a MedWatch system, and we need you to do that. So to make this possible, all right, so that they're not ignoring us, I'm going to give you guys a website, okay, and you can submit your story. I have done this. You can join us doing this, going to antidepressantinfo.org, okay? So that is where you're going to want to go, and then there's a / for FDA/reporting/program. But if you hit antidepressantinfo.org and you make a couple more clicks, you will get to the FDA reporting program. Go ahead and fill it out. It takes a little bit. But I think that this is another movement that we can all be a part of for those of us who have been directly impacted or indirectly impacted by SSRI or SNRI withdrawal. So,
and actually, it doesn't have to be just for withdrawal. If you've been negatively impacted, period, you can go to MedWatch and submit your story. So make sure you do that. I believe the deadline on that is October of 2025. So we got to get as many people on there as we possibly can. So, all right. Well, thank you everyone for joining us, and thank you, David Wayne, Batman.
My pleasure.